First. So again, thank you and welcome to everybody this morning. We have two great presentations for our session. I'd like to start first with Chuck Schneider and Redpoint Summit and the application that he has with the University of Nebraska Medical Center. And we have a great fortune of having one of the client representatives and Ron Carson available with us again this morning too. So Chuck, if you'd like to kick it off, I'll make sure that you can screen share here.
Yep, you bet. Yeah, I'll start talking and I'll try to share my screen at the same time. So Chuck Schneider, just quick intro. I was at Cerner for about 26 years, was one of the original 20 architects that started the creation of the Millennium EHR at Cerner. Dick, good to see you. It's been a while since we've chatted. So anyways, left Cerner a couple years ago and started Redpoint Summit, and we partnered with the Nebraska Med Center. So let me turn over to Ron and he can give himself a quick intro.
Yeah, good morning, everyone. Like I said, my name is Ron Carson. I'm the Executive Director for Enterprise Application Services here at Nebraska Medicine. We've got a relatively, I think we're a large organization, but I know compared to some of the people on the call, maybe we're not quite as large, but we've got around 25 clinics and 2 hospitals here in Omaha. We also serve as a community connect hub for 4 health systems that are in the western parts of Nebraska and central parts of Nebraska. So looking forward to getting to talk to all of you a little bit more about the partnership that we did with Redpoint Summit.
Okay, so with that, we only have a handful of slides, but if you guys have questions as we go, you can feel free to interrupt, or you can hold your questions till the end. It's up to you. So one, just starting with framing the problem that Redpoint we're trying to solve. So it's really 2. So one, the lack of standardization of order sets create a lot of variance and extra cost amongst health systems. And really the second is around physician burnout as it pertains to the EHR. So as folks know, that the EHRs can provoke quite a bit of frustration if users don't have things set up properly. And so just a few quick stats here of, 8 out of 10 physicians are burned out. And for every 1 hour of patient face time, there's about 2 hours of keyboard time entering things into the EHR. And as some of you guys may know, there's a term called pajama time, which a lot of physicians will spend their day seeing patients and then not be able to complete their documentation. They go home and before they go to bed, they spend an hour or 2 finishing up their documentation, hence the name pajama time. And then standardization around order sets. I think everyone on this call knows what order sets are, but it's been proven the more adoption and usage of standardized order sets really increases efficiency and patient outcomes. So we're going to talk a little bit about that. So first around really the optimization of the EHR. So what we do, I'm going to just talk at a high level, and then Ron's going to go a little deeper. But at a high level, what we do is we turn the complexity into simplicity. And we do that is we go into the EHR and we're able to go analyze what each provider is doing on a repetitive basis. So we can analyze, what are the orders they place the most? What is how are they approaching documentation? Are they using templates? Their inbox or in basket? There's abilities to do quick actions and quick replies like templates across the chart. And we're able to go analyze that, and then we go build these profiles. So a lot of us have heard of physician champions. Usually it's the handful of physicians at an organization that really do great things within the EHR, and they're very efficient. So through our analysis, we're able to go identify those patterns at an individual level, build that configuration into the EHR, and then the result of that is then almost everybody gets to be a physician champion because their EHR is optimized. So with that, I will turn it over to Ron.
Yeah, I thought something that would be helpful for this presentation is to just try to lay some of the context for why we wanted to do this partnership with Redpoint, and really kind of leads into a lot of those things Chuck just described. So Nebraska Medicine, much like all of the health systems on this call throughout the last 3 years, have been experiencing really severe clinician burnout, a lot of our clinicians leaving the bedside. And the outcome today is that we're facing budget constraints because of the amount of travelers that we are having to employ in our units. So as we started to look at this, we were really trying to take a people, process, then technology approach to it. We started with what can we do from a training perspective? We did all of the people interventions that we could think of. We did the physician optimization sprints that people have heard that CU Health has talked about many times. We modernized our approach to training and converted much of that to be module-based training. Along with that, we created physician efficiency training, which we had outstanding CSAT scores on. And then we really revitalized our governance process and created a much more robust kind of business relationship management out of IT with all of the service lines across the hospital. When we looked at some of the information that had come out of the Class Arch Collaborative a few years ago, we felt like that really addressed 3 of the big pillars that Class identified. The one pillar that we really had not addressed through all of that work was looking at how you can to give providers personalization. That's what really led us into this technology side of solving this people process technology problem. A lot of the information from Class highly supports that provider satisfaction with the EHR goes up when they can do personalization. The problem we had at the hospital was we would do training, but we never really had the time through that training to be able to help physicians do personalization. We would teach them how to do it, generally in a playground environment, but that learning of how never turned into practically making those personalizations inside the EHR in the production environment. That was what led us then to working with Redpoint, and really you'll hear Chuck talk a little bit more about this idea of a physician profile. But the profile is really holistic. We wanted to just start at a really granular level to say, can we get medication favorites or can we get order favorites so that they are now working off of a personalized view of the EHR from an ordering perspective, and then can we begin to attack some of the other things? So with that, Chuck, I'll turn it back to you.
Yeah, so to go describe just kind of these favorites a little bit more is, I think everyone knows the Cerner and Epic systems have favorites capabilities, but kind of like Ron mentioned of, if physicians do show up for training, most of them don't take the time to go actually build their favorites because they don't remember how, or they don't have time. So, real deep here on this for a second is we go through, we identify what are the top 20 medications that each individual physician places. And then we're able to go through automation, go and build those favorites for each ordering user within the system. So by using automation, we're able to do this optimization, personalization at scale, where traditionally it's either left up to the user or to the IT department or a third-party consulting company to go talk with a physician, ask what they place, and then mainly go build that. So let me keep moving on. So that's the optimization side. And so then the next thing that we're talking about, so we haven't made as much progress, but this is a future statement, is around the adoption of standardization of order sets. So I think most people realize that there are real advantages of working off standardized order sets. It's the adoption part where how do you get physicians to actually go and use them? So again, through our analysis, we're able to go through and identify. We start with talking to the hospital, like what are the top 10 revenue generating patient conditions, and we go through and analyze, okay, what are the diagnoses associated with those conditions, and then what are the order sets that map to those diagnoses. We're then able to go identify, okay, how many times were those order sets actually placed for those diagnoses? So you may have a pneumonia order set and only 20% of the time that order set is used. So we can go through and calculate a savings of, if that was bumped to 50% or 80% usage, here's the results of that. And then since we're able to track, at the individual level, what are people placing? There's 3 reasons why people may not use an order set. 1, they're not aware of it. 2, it may not exist. Or 3, they see it more cumbersome than the value that it's supposed to provide. So we can look, if there's an order set with 20 items and 90% of the time this user is, unchecking or checking, basically changing the defaults of the order set, that's a lot of clicks, and that may not be giving them the value. So they may be seeing a certain type of patient, and maybe there needs to be a new order set created and customized for them. So once we have that individual ordering patterns, then we can go push notifications and education back to that user that's tailored exactly to them. Example, we noticed last week you saw 8 patients with this diagnosis. Did you know there's a pneumonia order set that you could use that'll save you, 30 clicks every time you see a patient like this? Do you want us to add that to your favorites? Or we go do a passive alert within the chart to let them know that. So that's just kind of the high level. And so, benefits, which Ron and I both just kind of discussed of, as you have a tuned EHR, your patient throughput becomes quicker because the physicians are not spending so much time struggling through the EHR. Obviously that creates efficiency. And so, with a profile, then, there's about 30 minutes of savings per day once the entire profile is built, and a reduction of burnout. And then the standardized order sets, I think I already, covered of, as you're going through a standardized set, you don't have to use quite as much cognitive load of what is next. There's plenty of studies of the reduction of risk of morbidity. And then, reducing variance reduces the cost of the health system. So with that, we wanted to keep it brief and high level because we know these meetings are always action packed. I used to be at these meetings regularly quite a few years ago, but what questions do you guys have?
One thing, Chuck, if you let me just jump in real quick. One of the things that I want to add is, Nebraska Medicine is an academic medical center also. So we have learners who run the full spectrum of education. And something that is really helpful about, what we are looking at with Redpoint also is to be able to come back to some of those learners to say, your ordering pattern or what you are getting ready to do here is not in alignment with best practice within this division. And yes, it's true that they're being overseen by residents, they're being overseen by attendings. But this just helps to move some of the decision-making a little closer to that learner so that they can learn in a much shorter feedback loop than what they might learn otherwise if they go back to their attending or to their supervising resident. So we look at it too from that standpoint of how do we keep that learning loop as close to the learner as possible. And this is one of the ways that we felt like we could do that. Paul, you put a question in or a comment, maybe, I don't know, I don't see a question mark. So maybe you're putting a comment, which I think is a really insightful comment. And it is something that we have been thinking about. When we thought about this idea of personalization, we did want to be really careful because how do you make sure that a provider that isn't just going off the rails on kind of the way they want to do it, as opposed to the best practice or evidence-based way of placing orders? So what we have been talking about is that the personalization can happen kind of at a specialty level. So a new provider joins the organization and they would get sort of the pre-built personalization for that specialty. They can augment on top of that, but we want to be able to give kind of the standard that would say, if you're an ENT physician, if you're within our cardiology departments, these are the baselines that we expect for all of those providers to be able to work in. And the challenge we have today is that we don't have any of that content I want to say we don't have any. We have limited content built out at a specialty level. So the automation that we're talking about with Redpoint and Chuck's team is how we can automate that profile in for a physician on day one without them having to go build it. And now they're just getting to either accept the system best practices, or they can augment on top of that system best practice. So I don't know if that kind of gets Paul at what your comment is there. I think your comment's great, and it is exactly something that we've been thinking about.
I guess I might have a question. You had mentioned travelers, Ron. Could you say a little bit more about what that's about?
Yeah, so in that case, I'm talking primarily that we have had to bring in a lot of contract labor on our nursing workforce. We had a lot of folks who have left from healthcare as a result of the pandemic. Looking at retirement looked a lot more enticing than staying in the kind of complex changing healthcare environment. So we've had to do a lot of staff augmentation through contract labor to help offset that.
I see. So effectively, you're establishing through these order sets a sense of best practice, and I'm assuming that there's some evidence base under that. And how do you develop the evidence base?
So yeah, I can jump in there. So kind of step one is understanding how your order sets are being used, and then pushing that adoption. And then kind of step two is Zinx is a reference evidence-based third party that we pull in, and so then that is the external source of where we get our evidence-based content.
Okay. Is the client able to adjust that then?
Oh yeah, absolutely. I mean, it's evidence is the starting place, but as everyone says, you see one hospital, you've seen one hospital. So
Right.
there's always opinions and changes.
Well, and to add to what Chuck is saying there, I think Nebraska Medicine, much like any other academic health center, we do create our own content. Nebraska Medicine was kind of ground zero during the Ebola outbreak. And when COVID started, all of the Diamond Princess people were brought to our national quarantine unit. So, when we think about that evidence-based best practice, there are things that we have created, and we want to be able to put that into the hands of our clinicians through this personalization. And so that does mean that there's things that we develop here that may have to override what we would get from Zinx.
Right. There was a question in reference to patient education. Is there any role for that? Doug Hoovelin asked if you support patient education in any way.
Currently, we have not done anything around patient education. But if you've got thoughts of maybe how something we've said triggered that thought, I'd be happy to have a chat about it for sure.
Yeah, and Chuck, I may be reaching out to you. I'm actually talking with a doctor. We're looking at generative AI for patient education, and just how AI in general can help. I'm just amazed at the two. I really like how you said, what problem are you trying to solve, right? For doctors, the burnout. I mean, working at KU School of Nursing, they're having burnout too. And if you ask, what do people hate? When I talk to people, what things do you hate about your job? It's usually difficult, dirty, dangerous, or dull, right? And if you're doing 2x more key time, a doctor is doing 2x more keyboard time than patient time, something's broken, right? And,
oh yeah, for sure. And I think the best definition I've heard of burnout that resonated was from an ER doc, and she said it's the inability to provide the care that I want, and it's for a lot of those reasons you just stated. That's the frustration. I can't provide the care that I want to give.
Yeah. If I'm doing stuff that I'm passionate about, which I mean, doctors, medical professionals, they want to provide care they want to give. I mean, and they probably love doing that. They hate doing keyboard time. So
Right.
Really excited about your solution. Thank you.
We had another question in the chat about how do you reconcile conflicts with insurance coverage guidelines and the evidence-based practice idea?
Let's see. So again, I mean, these are all conversations. So one for the favorites piece and identifying those patterns. For that's kind of the optimization of it's what the physician's doing today, and we're just helping them streamline what they're doing today. And so that's not necessarily trying to change behavior on that piece. That's just making them more efficient. The order set and evidence-based, again, like Ron was saying, is, you know, that doesn't just, we don't just pull in evidence and shove that into production. Those still go through clinical committee reviews and things like that. So it still gets, you know, people and real eyeballs on that before anything shifts. It's the scaling of being able to push individualized notifications to those users of, you know, okay, these are the people who need this order set because it's the type of patients that they see. And we can see that, you know, this person's only using it 12% of the time and this person's using it 90% of the time. So let's not beat to death the person who's doing it 90% of the time and go help the person that's not using it as much.
And I think maybe what's nice about this, and maybe this wasn't all the way clear in part of our presentation, but this is content that we then generate back into the EHR. So it would still take advantage of EHR tools that you have that are doing any eligibility checks. So it is not, we did not conceive of this as a way to sort of circumvent or go outside of that process.
Yeah, and maybe I'll just repeat, that's a good point of, this is data analytics on the back end, and then we use automation that builds this back into a Cerner Epic system using the Cerner Epic tools. So the user doesn't, it's not a separate app, it's not a Smart on Fire app or anything like that, a separate website. It's the EHR that the physician is currently using. It's just now configured so they can do their work better.
Okay, thank you. What other questions do we have?
Yeah, understanding the potential inherent conflict of interest, and I think maybe the target here is chronic condition, sort of best practice and standardization. But have you looked at potential partnerships with pharmaceutical manufacturers that are more in the rare disease space, where they would be interested in helping create standards around pre-diagnosis as a physician works through a set of labs, for instance, comes up to the point of diagnosis, formulary care on the patient, all automated through the EHR?
That's something we have not actively had a discussion. We had some very light and fluffy conversations with one pharmaceutical company quite a while back, but that kind of didn't go anywhere. So maybe I'll ping you here afterwards, and I'd love to pick your brain and go a little deeper on that.
Sure.
Yeah, and it also supports a theme that's actually kind of in the community right now, where BioNexus, one of our partners, BioNexus KC, is running a series of events on rare diseases. So that's very compatible to some of the discussions going on in the community today. Other questions?
Hey, Chuck, this Dick, are you seeing yourself as kind of a consulting offering, or do you see yourself as consulting and some unique IP that I think you mentioned about that personalization tool that could really simplify the on-site work?
So we do not see ourselves as a consulting organization. So most of this, the analysis is using our algorithms and our software. So it's not us going in and reviewing records manually. And then the build out, we're using RPA, robotic process automation. And again, the reason we use RPA is it's using the Cerner Epic tools. So that way, all the business logic and complexity that there is, we just leverage that. So, RPA, just for folks who don't know, it's basically automating a human and doing the clicks in the tool that a person manually would be using anyways. So there's a little bit of eyeballs from our side for, as we start going through these order sets, but the profiles that's all through algorithms that we go and identify and automation that we build it back.
And David Varan, do you want to share your thoughts? I thought I like your comments here, but it's a bit lengthy, so I give you a chance to kind of speak them out loud.
Well, I'm going to have to leave real quick, but
Okay.
have another meeting. But, you know, one of the things that we've noticed is back when I was going to med school and residency, we learned from other charts. And since then, and we would copy those, what worked. And since then, what's happened is the regulations have kind of tumbled back down to giving us physicians all the work that could easily be parsed out to others based on either protocols or intelligence of the system based on a diagnosis as to which of the sets of orders would be the most informative. And that's all been taken away from us from regulations forcing the physicians to actually do the work. And this applies to documentation too. We have to document a lot to justify payment, when if we change the regulations, a lot of this stuff could really be unleashed, and we could use some of the tools that have been describing today to really take away a lot of the work. We're one of the few industries in medicine that still regulations demand clicks, as opposed to other industries that have been free to eliminate work. And so I really applaud the work you're doing, but I can see a lot of issues with stuff on the ambulatory side that we have. Is we're bombarded every day because the patient's insurance denies something that's evidence-based. And we're seeing this over and over again, that costs then force the patient to come back, and we're not given that information up front from denial type stuff. So there's a lot of stuff outside the automation and the EMR that's actually driving and increasing the amount of work we're having to do. That's to physicians.
Yeah, definitely agree with that. Of, you know, the pre-auths are getting to become a crazy level. There is, on a positive note, you know, there's, what was that, 2 years ago, the MDM approach for documentation, which is supposed to reduce the amount of documentation required, which then does conflict with what you're just stating of insurance wants to see more. So there's some pros and some cons of what's happening. I don't know if MDM is being very aggressively pursued by a lot of folks, just because for the last 20 years, physicians have been trained how to do documentation and kind of more is better. And now that regulation is reversing that, I think it'll take years for folks to kind of re-identify what is the most efficient way a physician note should be. And as most of us know, talking about physician documentation is kind of like talking about religion of which one is the best. So it's a touchy subject for sure.
Well, I want to say that, Dr. Varan, what you're saying just resonates so much. We talked last night that for physicians to keep up with all of the, not just changing regulation, but changing science, some articles suggest that physicians would have to read around 400 articles a week just to keep up with the updating technology and updating regulation, which is staggering. So, you know, at the end of the day, what we need is systems that learn with our clinicians and can support that. And that's why I think some of what we've talked about, you know, some of what Chuck is talking about with this algorithm is, if, let's say, practice does change and physicians start ordering something different, there are times the EHR, it takes a change request to get that update then added into the EHR. What Redpoint Summit solution is attempting to do is to say, we see that ordering behavior change. Now we're going to go build that back to the EHR automatically. Now everything Chuck said is true. We still are going to take what the output of that is back to a group, whether it's, we have something called the multidisciplinary order set team, whether it's most that's going to review that, or whether it's a medical director over that specialty who's going to be the owner for the profile, be able to take it back to them. But the point that you're making is such a good one. It's, the burden is depressingly high on clinicians to keep up with the changes that are going on. So we need to get learning systems that can really come alongside and support clinicians in that effort. And that's something that, you know, we are hoping that this can help us with.
May I ask a question? Are you using Epic or Cerner as the major enterprise software? Maybe I missed that part.
So Ron at the Nebraska Med Center, they're using an Epic system, but for Redpoint, our target is Cerner or Epic. So either of those EHRs.
Okay, so would you consider yourself to be agnostic solutions that could attach to all of these enterprise systems?
Mostly agnostic. Our automation to build things back in, there's engineering effort per platform there. So, you know, currently we're just focused on Cerner and Epic. We've talked to lots of other smaller hospitals, and as you know, there's still a ton of other EHRs. We can definitely go extend that at a minimal effort, but we're still pretty small, so we're trying to stay focused on those two EHRs.
Because I seem to wonder if the problem that the physicians are stating also has to do with the collation of medical records in an EHR across systems. And if there were something like an additional software, I don't know how that would interact with that. Care Everywhere and Epic is incomplete to some degree and is very restrictive in how it shares and collates records. And that can, what I've found, make physicians when ordering unaware of frequency and outside testing. So that is a reason for the redundancy, and the outside records and reports may or may not already reflect what they are going to do. So sometimes when I see very specialized programs that do the automated or make the ordering easier for a physician, I kind of see a compounded problem on the top. But if it's more agnostic, then it could be good. I just wanted to put that in there. It kind of addressed the problem of physicians and ordering and the collation of records in an EHR. And that goes a lot to the insurance as well. So.
Yep. I'll just keep my response short of I totally agree. The more information and interoperability, the better the decision making is for the physician. John, you're on mute if you're.
Yeah, I noticed that Tess also asked a question, and I think that is directed to Nebraska Medicine. So I'll just answer that. No, we're not currently showing the technology we're talking about today. It's not currently going back to students. But I think that is a very realistic use case for us in the future. And to the point that I made about trying to shorten the feedback loop for learning, getting it all the way back into med school, nursing school, like you can't get a much better feedback loop than that.
Yeah,
great. Thanks.
I'll add to that real quick the use cases we've talked about is definitely med students, any kind of student. And as the rotations go through, do you just inherit the profile of your now new attending? And then this is also beneficial for when you onboard a new AHR user. You can go take that peer group's profile and apply it to them, so they can just jump in and learn and kind of be up to speed with their peers.
Yeah, and just to really pull that thread that Chuck just mentioned. So as a organization that has a residency program, as residents move from emergency medicine to the ICU to labor and delivery, they're not getting the best practice of that. They're having to go ask their attending because their profiles are configured to what their home discipline was. An emergency medicine resident basically moves around with that profile. And so what we really want to be able to do as we go through this is that as the resident starts day one as a labor and delivery resident, they start with the best practice configuration. And to the point Ryan's making about data review, that's a real problem for a resident who's going to a new department and they don't recognize the screens they may have to look at now. So making sure that the data that's being presented to them is best practice for the specialty that they're in can really help them to onboard more quickly rather than, oh, I've got to go find my wrench and I'm going to wrench in this favorite report now. And then 3 days later, they find out they have to go wrench in a different favorite report because now they're seeing a different patient presentation than what they had their first shift. So that's a lot of that is what we are really trying to solve for here. And it's a complex problem to solve and to try to get all of those things right.
Great, thank you.
Any other questions? I think we really got into this. I'm really pleased of the interchange that we've had here, and particularly having Ron with us was really important to understand it from the client's perspective. And so we thank you very much for this.
Yeah.
And then hope that we'll have a chance maybe to follow up with you at some other time to see how it's going.
They're going to get the professional.
Yeah, that'd be great. Thanks for giving Chuck and I the opportunity. I had a great time this morning.
Great, thank you, Ron.
And go back if you don't like.
Okay, we've had a few people join us since we started. I'd like to give them a chance just to quickly introduce themselves. Amy, are you with us?
Where are you taking them? It's mine.
Amy?
We take minutes.
Okay.
When
How about Tess? Let's hear from Tess.
They lost their groomer.
Yeah, am I just introducing myself?
Yes, that's all.
Okay, so I'm Tess McKinney. I work full-time for UNMC, so University of Nebraska Medical Center, at the Global Center for Health Security.
She has to get her
Nails
trimmed, and so like I used to just take her to
Great,
the
thank you.
Well, they raise the prices, and it's like
I also own a company in XR, VR, and AR called XR Renegades.
Okay, great.
All right, so it's $30 to get a bath.
Tess, did you participate at all in the
And it's only
AR/VR
60
challenge
bucks
that
to
we
get
had
haircut
that
and
involved the
fucking
University of
thing.
Nebraska?
I actually didn't. That was I was at a different part of the college at that time. So, but thanks. It sounded great.
About Max, maybe he doesn't ever have a problem with it.
Okay.
But John, she did come down and join us at the VRARA meeting. So she drove down from Nebraska to join us at that last meeting. So she's involved with us. So
yeah,
good to know.
Yeah.
Thank you. Welcome, Tess.
Thank you.
Okay, Aaron.
Hi, Aaron Deacon, KC Digital Drive.
Jeff.
Hey, Jeff Blackwood with New Frontier Mobile Diagnostics. We do on-site diagnostic imaging in doctors' offices and clinics.
Great, thank you. Paul.
Hello, Paul Dow. I'm the eHealth Innovation Adoption Strategist at the American Academy of Family Physicians. I'm a health informatician with also a background in cardiology and X-ray. I am not a physician, but I work a lot with them. Thank you.
Great, welcome. Anybody that I've missed? Okay, let us go to our next presentation and invite Meredith McAllister to speak to us about Marma Nutrition and a new application starting up in that area. So welcome, Meredith.
Thank you so much. I'm really excited to be here this morning, and we're shifting gears just a little bit. Let me pull up my screen so I can go through my presentation.
Great.
All right. Are you all able to see this?
Yes.
Okay, perfect. As I mentioned, I'm Meredith McAllister, CEO and co-founder of Marma. So 97% of pregnant people are taking a prenatal vitamin. However, 95% are still nutritionally deficient. What this means is that they aren't getting the nutrients that they need during one of the most important times of their life. So nutritional vulnerability, when our bodies need the most nutrients, is in that preconception, pregnancy, and postpartum phase of life. When you aren't getting enough nutrients or the right nutrients, that leads you to an increased risk of labor complications, postpartum complications, maybe some struggles to get pregnant. But the problem is that there's really simply lack of clarity around where to get the correct information on where to eat or what to eat, what nutrients to focus on. The information that does exist, it's outdated, it's conflicting. You're looking at Dr. Google for answers. Our OBGYN's appointments are far too short to answer the breadth of questions. And most people are turning to blogs that are maybe from 2014 with really outdated and not credible information. So our solution is Marma. We're creating a platform, we've built out our mobile app that's created by nutritionists, reviewed by OBGYNs, and it provides mothers and birthing people the information that they need during that conception, pregnancy, and postpartum phase of life, all within their mobile app in the palm of their hand. We built Marma out to have personalized week by week information. So every single week that they can go in, they can be 7 weeks pregnant, they can be 6 months postpartum, and it will say, here's what's happening in your body, here's what's happening with baby, and then here are the nutrients that you should be focused on getting. They can then click into those nutrients, see how much is recommended during this phase of life, and then recipes to support that. So they can go into the recipe segment where there are hundreds of recipes, indicate I'm in my second trimester, I would like to focus on getting more zinc, and then all those recipes will show up. Additionally, they have the ability to chat in the app with a certified nutrition coach that specializes in pregnancy, postpartum nutrition. We're building out an option to have the ability to order an at-home test kit, and then they would be connected with a coach that would review those results with them. The other differentiating factor for Marma, again, is that we capture the user from that fertility part of their life all the way through a year postpartum. So we're, unlike a lot of other pregnancy apps, and I'll go into this later, that are there for that, just that pregnancy portion. And then as soon as you have the baby, they drop you and you're on to diaper changes and feedings. We are with our users all the way through that first year. We're creating a community that provides this nutritional guidance when it matters the most. So we're combining those certified nutrition coaches that focus on pregnancy, postpartum nutrition, as well as offering OBGYN and RD approved content, and then creating that community with those nutrition coaches, and then eventually offering the ability to interact with other users. In the United States alone, there are around 7.2 million pregnant and postpartum people every year, and around half of those are downloading a pregnancy app to support them on their journey. We know that the global pregnancy mobile health
I've lost Meredith. Is it the same for others?
Okay, I'm back.
Yes.
You froze.
That's so weird. I have literally, that has never happened in all this time on Zoom. So wouldn't you know, it's
Meredith, when I lost you, you were covering the fact that about half the people had downloaded an app.
okay, great. Well, you didn't miss too much. I'll pick up right there. Okay, so as I had mentioned, there are around 7.2 pregnant and postpartum people in the United States alone. Over half of those people are downloading a pregnancy app to support them on their journey. What we know is that the global pregnancy mobile health app market is expected to be $4.2 billion in 2023, and then expected to grow to $13.2 billion by 2031. And this is because women are ready to take control of their own health. They want the information accessible. They want it in their own hands. They don't want to have to go to a bunch of different sources. They want to know what is best for them so that they can make decisions for themselves. And what's really interesting is that we are at this turning point for women's health as a whole. So whether that is, we're seeing more fertility support and egg freezing options, endometriosis support. There are more menopause and perimenopause companies. There is a focus on women's health. And a lot of this is because healthcare is expanding beyond the hospital. Women are seeking alternative treatments. They're ready to take control of their own health. And what's wild is, and not surprising, but 80% of healthcare decisions are made by women. Women are usually making decisions for themselves, oftentimes for their partners, oftentimes for their kids. And now more and more, we're seeing that they're making those decisions for their parents as well. So what Marma specifically offers, we are building this out. So we are direct to consumer. We're building this out with a basic offering. This is week by week information. They can go in. This is all free. They can see what nutrients they need to be focusing on, look into their symptoms and cravings, and see if that might be tied to a nutritional deficiency. So for an example, if I am craving chocolate, that could be related to a magnesium deficiency. So how can they, in a healthy way, support that? Our premium offering allows them access to hundreds of recipes. Again, as I had mentioned, the ability to filter out through where they are specifically in their pregnancy, postpartum journey, and if they need to focus on any certain nutrients. And then we also have that chat. So all within the app, they can connect to a certified nutrition coach who can tell them, dive down into what they might be experiencing and offer some support with that. And we do foresee, especially in the next year, building out, leaning into our enterprise options, so making this available to small businesses as an offering for their employees. As we know, healthier pregnancies means healthier delivery and likely a quicker return to work. So we are bringing this to market through healthcare providers and health systems. We already have a number of healthcare providers in the Kansas City Metro and beyond who are partnering with us to recommend Marma to their patients. And then also brand partnerships. So there are really some incredible companies out there that are leading in the maternity postpartum space. So we're starting those conversations with them. Leaning into social media. So again, organic and paid campaigns, and then partnering with influencers who are in the kind of wellness pregnancy space. And as we go into 2023, looking into the insurance cost sharing partners, so expanding our B2B2C model. We have launched our beta in early January. So we really kicked off 2023 with a bang, launched the beta, have over 500 users, and we'll be focusing on that user growth in the next year. What makes us different is that we are going through healthcare providers. We know that this is a trusted resource. We want to be a partner with OBGYNs and midwives when those appointment times can be really short, and that 15 minutes might be the time that they are taking measurements. They're looking at the baby's health, at the mom's health, and that time for questions is really limited. So we want to be a resource that those doctors and midwives can recommend to their patients. So when they say, can I have sushi? It's honestly a nuanced question. Well, it depends. Are you going to the gas station? Or are you going to somewhere that's really preparing it well? So have it just, rather than diving into all that, saying here's Marma, you can look into that. If you have specific questions, then you can dive in and learn and empower yourself. That expert nutrition focused content, supporting our users from the very moment throughout all the birthing years. So when they decide, hey, I think I'm ready to start trying to have a baby, they are downloading Marma on their phone and then supporting them all the way through that postpartum period. We know that when there are fewer nutritional deficiencies, that it leads to better birthing outcomes. There are definitely some other pregnancy apps out there, but they just fall short. They provide maybe your baby is the size of a banana, and this is about this size, and then that's about it. So we really want to have that full wide range of what's happening with you, with your baby, and here's how to support and empower yourself. Where we are. So we've launched our beta. As I mentioned, we are currently in development for our fertility segment. We hope to launch that in the next few weeks, and that will really be supporting the user and the woman through their cycles. So wherever they are in their cycle, that there are different foods and movement that you can do to support your body, get it ready to build a baby. And then in this next year, we'll be really launching or really focused on our user growth. So focusing on expanding our development and especially looking into our marketing. Who we are. As I mentioned, Meredith McAllister, prior to this, I started a compost company, and I sold that actually right before I had my second baby over almost 1.5 years ago. And it was in that time that I had actually worked with Victoria, who is a certified pregnancy postpartum nutritionist. She has her own company, Nettle and Honey, that is kind of concierge doula food service. Really incredible wealth of knowledge. I hired her. I have a background in studying nutrition. However, it's not specific to pregnancy postpartum. I worked with her. I felt immensely better, truly, in my pregnancy and postpartum. Even with a toddler running around and a newborn, I had more energy, and I attribute all that really to nourishing myself. And then prior to the compost company, I was working at a market research firm. We are ready to go. So thank you so much. If you have any questions, I am all ears. I'll leave my screen up for just a moment if you want to scan the code. My email is there as well if you have any questions and want to reach out directly. But thank you all.
This is great, Meredith. It's particularly relevant right now, and specifically in Kansas City. There are several initiatives going on to address the fact that the Kansas City area has extraordinarily high maternal death as well as infant death through the birthing process. And so there's just so much attention being paid to it, but one would think that a lot of it has to do with really poor processes in terms of managing through fertility to postpartum. And so the fact that you cover that entire range just seems to me to be vital. Is that what was your thinking in terms of trying to cover the entire range?
Yeah, so in the United States, our maternal morbidity rate is far higher than it should be for a developed country. And certainly we know that nutritional deficiencies are playing a part in that. We know we can't solve for all of that. And to be honest, our target user is somebody who is wellness curious, who is somebody who is already interested in nutrition and wanting to do better. That being said, we felt it was really important to offer Marma to be at that free version. And we hope to spend a lot of our energy in the next year in working with partners who can spread the word. Like this is a free offering that you can look and you can see here are the nutrients to focus on. Here are different foods that you can eat to support your pregnancy, and just some really slight changes to your diet can have a really significant impact in the birth outcome.
That's very interesting. We have a nice comment here from Paul about this being useful in family practices as well, in terms of your current and target audience.
Yeah, we definitely see this as being, we view Marma as being the nutritional resource during the birthing years. So whether you're pregnant or thinking about it, that all of this information is easily accessible.
Okay. One of the questions from the chat is, how do you account for issues such as nutritional needs for women with medical disorders that already put them at a deficit of nutrients, or issues with the baby in utero that indicate it might have different nutritional needs?
So I will say that is something that they will definitely want to work with their provider on. I would imagine in that situation that they're working with maternal fetal medicine specialist and making sure that they are talking with them to go deeper. Throughout the app, we are not a medical provider. We say check with your medical provider before making any sort of big shifts. What we really aim to do is to provide some information on here, you're building a human. So here are some small changes that you can make, and getting those, filling some of those gaps, those deficiencies through food. However, check with your provider, and especially if there is something more going on, if you are at experiencing a high risk pregnancy, absolutely be in communication with your doctor before going all in on making some big decisions.
Doug, did you have a thought?
Yeah, one question was, what % of poor outcomes happen because of lack of education? Is there any data on that, and from that perspective?
So I don't know a specific statistic for directly linking nutrition to a poor birthing outcome. It's a little bit tricky because it's a wide breadth. You can experience just a deficiency in iron, but then also have a number of other health conditions. So it's what we're really focused on is that almost every pregnant person has some nutritional deficiency. Again, that can be so slight. It could be vitamin B12 and you're just a little bit more fatigued, or it can be it can be a number of different things that can have a significant impact on your outcome. What we do also know is that the number, as we mentioned, the number of poor birthing outcomes in the United States is just far too high. So if MARBA can play a small part in helping people be more or less deficient, then let's do it.
And is it just nutrition, or is there like exercise or other activities or other practices they could do?
At this point, we're just focused on nutrition. We do see eventually, possibly, if our users, if that's kind of where we're headed, adding in some movement or meditation, breathing exercises. You're headed into an appointment. Here's some breathing techniques that you can do to help calm things down. But at this point, we're focused on nutrition.
Okay.
Somewhat in that regard, are you looking at this from a perspective of social determinants of health as well? Those moms that are at higher risk tend to have more going on in that regard. So the questioner wondered what research you might have in that arena.
Ooh, that's a really great question. And we really haven't dived into it, but I think that that's a good, something worth exploring more.
Yeah, as I mentioned, there are several programs going on in the Kansas City area on maternal health currently. And so this might be very relevant to that.
Yeah, absolutely.
And somewhat related, have you tested content for cultural or racial perspectives?
We have not to date. We just launched the beta a month ago. It is on our radar in the next year yeah. I mean, all of our recipes, the way that we communicate, having a full audit on that.
Okay. Do you have an option for substitutions within the app for patients that have a food allergy or sensitivity?
We do, and it's really broad at this point. So you can filter out by gluten or lactose, dairy, a number of more common food allergies. It doesn't go deep on all of them. I think eventually that would be a really great feature. But at this point, it really is, you are able to filter by certain allergies or diets. If you're pescatarian or vegetarian, what you'll see would be filtered to your diet, and then common allergens.
Okay, great. Danny, you have several questions. I might just invite you to go ahead and ask them if you could.
Sure. One of my questions is just from a user perspective. You start with an app, you get excited about it and everything is going good, but then the excitement or the motivation wears off. Do you offer any sort of push notifications or reminders?
Yeah, great question. So we are building that out as we speak. Actually, with some of the sandbox funding, we'll be implementing push notifications. So every week they'll get a notification since there'll be another week along in their pregnancy or postpartum journey. So yes, that is definitely something that we are building out now.
And is it something that they can come, maybe they missed week 18, 19, and 20. Can they come back at 21 and be caught up? Or do they need to go back and make nutritional differences from before?
Nope, they would be caught up. They would say, congratulations, you're in week 21. If they had that interest in learning about the prior weeks, they're able to go in and see what was happening, but they don't need to go and check any boxes. They would just automatically be dropped in week 21.
Okay, it's a great product.
Thank you.
Great.
I had a question real quick.
Yes.
It almost seems like a prototype for telehealth. And I saw you had some insurance on the roadmap down there. And I have been working with some telehealth IEEE workshops and work streams. And it almost seems like it would be advantageous for you. It's just a little suggestion to add in the genetic testing, and then you can have the phenotypes or your social determinants added in with the genetic testing, because that's where I think the telehealth direction is going to go, and what they call like P4 to P5 medicine, is to collate those together. Might want to look into that. I know you're really busy and it looks great. But you could add those into your nutritional services, the counseling. You could also have the genetic counseling. So yeah, they're really expensive. I know genetic counselors are expensive, but but yes, yeah.
Yeah, I definitely think that you're right. We're in such an interesting time. Women's health, but then also health in general is just it. We want so much information, and this pregnancy, postpartum, fertility phase of life, we want a lot of information. And I think that there is the ability or the potential to go really deep if you want to. And I definitely see that there could be some really incredible integrations to offer those people who are like, I want to know everything so that I can really best support this whole fertility pregnancy journey. So yes, I definitely think that that's a potential.
Yeah, because that has the determinants of health in there. So anyway, yeah.
Right. Thank you, Ryan. The somewhat related question is, are patient lab values incorporated in any way?
So we are in the next year, 6 months to a year, we'll be working with a company I'm aware who does the at-home testing, and they have an API that would integrate the patient's results from those. We would suggest doing that when they're right before they're trying to conceive, when they're pregnant, and 12 plus weeks postpartum. So those results would be in the app. Yeah.
Oh, that's great. That's really great. I had a question. What actually happens with the at-home testing kit? What's involved there?
So I'm aware already. It's a company. They'll white label the whole kit for Marma, and we'll select which markers we want to test for. They send the box, you do a finger prick and send the results back, and then they would integrate those results into the app. So very simple.
That's very interesting. But I thought you had also mentioned that you have some sort of kit that goes home today to homes. Is that correct, or did I miss that?
Yep. So at this point, you can get a kit from, and it is through I'm Aware, but
Okay.
it is not white labeled at this point. It's just their kind of broad general women's health kit. And then in the very near future, we'll have a white labeled specific to MARMA. We pick the markers. And that kit will be, it's currently $160. Price is probably going to be around there for the MARMA kit once we figure out cost on what exactly we'll be testing for. But as it is today, it's $160.
Okay, that's great. Thank you. Any other questions?
How are you attracting your users?
So right now we are, again, working with the OBGYN. So in office, there are flyers when you are pregnant. We already have our flyers going home with a couple of different birth centers and OBGYN groups in Kansas City, and then also through social media, and we'll be doing some paid campaigns soon.
I would maybe add a suggestion of, especially in lower income areas, it's harder to find resources or for people to even access information like this. Maybe some sort of demonstration or speaking engagement on your part, maybe at a local food pantry or something like that.
Yeah, that's a great idea.
Yeah, thanks, Danny. That's great. Other questions? And Ashley has suggested another extension as well in terms of maybe being able to show where certain things can be bought at a store nearby.
Love that. Yes, we've thought about that. We also, it's so hard. So we just launched the beta, and it's so hard to not go all the different directions. But I think that there's also an opportunity for a grocery API integrated into the app, so that you can say, okay, I'm in week 17. Here are the click and order the foods show up at my doorstep later that day of foods that are going to support me in the next week.
Maybe even further, I know you're just started and everything like that, but that actually brings up kind of a good point of, you have all these at-home meal delivery kits. You're pregnant for 9 months, and then afterwards and a little bit before when trying to conceive. Maybe that's in your future, some at-home delivery kits each week for those nutritional needs, or partner with somebody like Plated.
Yep, absolutely.
Hey, Meredith, this is Dick. I would encourage you to stay focused as you have been answering these questions. I appreciate you talk about, I think you're on to something here. And as we've talked about briefly, I think really on the postpartum side, I think that's the missing link. There's a lot of people going after this pregnancy period. And very few people have gone into that transition, particularly for nursing moms. So I think you're onto something. I think staying focused and really proving out this value proposition. I love the way you're thinking about a consumer first, but a provider validated or something, because one of the things we've learned is that keeping that connection with the most trusted actor on the healthcare stage, which is still the provider, is just a wonderful way to build credibility for your app, your company, and frankly, for the good work you're doing. So I think you're onto something here. And I like the fact that you're answering these questions. Good idea. But we're going to stay focused on this right now, because I think everybody in this call knows that's, it's so easy to get distracted. So good stuff.
Yeah, thank you.
Well, I think Dick makes a great point. I do, though, enjoy very much the interplay that we have in this group about really thinking about the problem at hand and being able to offer feedback to one another. It's really very welcome, and thank you all very much for that. So any other further questions before we go?
I'd like to make a comment.
Sure.
Nice to see you, Meredith. Yes, to what I fully support what Dick gave you as far as guidance. A couple of thoughts in terms of what was thrown out there to think about. Be careful on anything that looks like a prescribed set of foods for people. You walk into this new emerging area, which is medical nutrition therapy. And that's quite controversial, is what I have found in my work in the nutrition space. Some people very much believe it can be scaled into the community. Other people are saying it's just impossible and kind of put you in the crosshairs pretty deeply in the clinical discussions around that. So I think as much as you can keep general, educational, supportive, allow people to make independent decisions, you're going to have the greatest success with your app.
Great feedback. Thank you.
Well, I think we've kind of brought it home there. Is there anything else before we go? Meredith, this is really great. Thank you so much for being with us today and sharing this with us. As Dick said, you seem to be on to the right topic, and it makes a lot of sense. And I sense that from the group that you really elicited a lot of excitement. So congratulations and thank you.
Thank you so much. This was really, really fun. I enjoyed speaking with you all.
Great. So we'll leave it for there, everyone. We will reconvene next month. And as Danny Hatch mentioned before she had to leave, she'll be one of our presenters, and look forward to that. And we'll be mailing out the links to this recording as well as the agenda for the next month's meeting shortly. So thank you all very much and look forward to seeing you again soon.
Thank you.
Bye now.